Hi, I'm Dr. Eric Westman, and this is the Keto Made Simple podcast.
Hi, everyone. Dr. Eric Westman here, and welcome back to my YouTube channel, or if you're watching with Adapt Your Life Academy, great to see you. From time to time, I get to ask people who I think are the movers and shakers in the low-carb, keto, or medical world. And today, it's my great pleasure to have Dr. Eric Kirchhoff. How are you doing, Eric?
Good. Thanks for inviting me, Eric.
My pleasure. And for those who don't know who you are, and maybe because I think you're the pediatric neurologist, if that's right. And
Yep.
So many of my viewers are in the adult medicine space. So who are you? What do you do? How did you get into this area? How could I possibly be interviewing you? I mean, it's great to have you.
No, sure. Yeah, so I am, as you correctly said, I'm a pediatric neurologist. I take care of children with various neurologic diseases, although most of my time, about 95% of my time, is epilepsy. I've been doing it here at Johns Hopkins in Baltimore for about 25 years now. I started down in Virginia, did my training here in Baltimore, and then never left. Early in my training, I met Dr. John Freeman and Dr. Patty Vining, and they were running the Ketogenic Diet Center for Children here at Hopkins for probably about 15 to 20 years when I arrived. And it just blew me away. I thought it was incredibly interesting. I had really never heard of it before in my pediatric training or in medical school. And so I kind of followed them around and did a little bit of research as a resident and epilepsy fellow, and then decided that I wanted to make it my career. And around the time I became faculty, Dr. Freeman retired. And so I took over the pediatric program, which has continued to grow. And I'm very involved continually with children with epilepsy. I'm the, I guess, sort of associate kind of director of our adult epilepsy diet center, which is very exciting. Dr. Mackenzie Cervenka runs that, but I help and assist, and it's exciting to see that. And occasionally we collaborate with others like you and others who are working on fields other than epilepsy and ask our advice and help. So, yeah, it's been an interesting career, and love the ketogenic diet. It's a lot of work, but a lot of rewarding fun too.
So what year would it, when you came through training and when you went to Johns Hopkins to learn about this?
Yeah, so I started my training in 1998, and then it was probably about 2000, 2001 that I finished my fellowship, came onto the faculty. So yeah, almost 25 years ago.
Well, let's just start with that question about your typical patient.
Right. So, I see a lot of children from around the mid-Atlantic area and sometimes other countries and parts of the U.S. too, with typically refractory epilepsy, meaning they have seizures, they've not responded to 2 or 3 or sometimes many more medications. Many times they've been evaluated to see if they could have epilepsy surgery, which in many cases can be a cure, but it's not always appropriate for every child, and sometimes the families don't desire that. So they get referred to me to say, are there other options? Families have heard about the ketogenic diet quite a bit now. The last 20 years have been exciting just for public awareness through a lot of your work and others. So families are familiar with it. Some of them have even tried sort of dabbling in it on their own. And so we meet with them. My dietitian meets with them. We explain kind of how we do it for a medical ketogenic diet for children, how we usually typically admit children and gradually start them on it, and what follow-up would look like. We explain to families that for most of them, it's a combination of medications and the diet. About 80% of our kids are on both. But if they do well, we can lower medicine, sometimes reduce medicine, and obviously that's ideal if we can pull that off too. A lot of them have better cognitive improvement as well. So we go through that with the family and make sure that they understand sort of what the ketogenic diet program at Hopkins is like, and then shortly after we'll get them started. It's been great. We see babies, we see sort of toddlers, and definitely see a lot of adolescents, although we tend to use more of a modified Atkins diet for most of the teenagers. But for the most part, it's sort of a discussion in the clinic about what it's going to be like, and make sure the family has good goals and expectations.
Yeah. So when you counsel someone about the diet change for epilepsy, what percent of the children have total resolution? Like, let's say, even without meds, does that ever happen?
Oh, for sure. Yeah. I mean, that's what makes it so exciting. So, if you look at the statistics before we even talk about the diet, medications certainly work. But if you've tried 2 or 3 or 4 medicines, the chance of seizure freedom starts to drop pretty quickly. For the first drug you pick, could be like 50% seizure free. But if you go down to drug number 3 or 4, it gets to close to about 5%. Not zero. It's why we still keep trying new drugs in many of the cases. But, probably about a 1 out of 20 chance that they're going to become seizure free with that new shiny medication that's out there.
Yeah, that's not great.
No, it's not for sure. And that's again why the families look for other options and say, what else do you have? The diet, no matter actually what the age is, gender, where you are in the world, in fact, it's probably around 15% seizure freedom. So 3 times as high with trying a dietary therapy. And that's why we often think about it and talk to families about using it. In fact, there's a lot of research now looking at doing it sooner, not waiting until you've tried so many medications, because there's no reason to think it wouldn't be successful using it first or second.
So that's 15% will have total remission of epilepsy by the ketogenic diet.
Yep. That's exactly. That's all comers, so there's,
that it's amazing. And
yeah,
I wonder even, would it be higher if you didn't have the referral selection bias? So you're probably getting the worst cases now, right?
Well, it's interesting, Eric. I think that was probably true maybe 10, 15 years ago. We were sort of the therapy of last resort. Families were sent to us or found out about us because they just were desperate, had nothing else, that was being offered by their center. And even those kids, again, you look at the data, it's like 15%, which is remarkable. What I think has started to change is, I think as a community of neurologists, we're starting to realize there are specific indications that are more responsive to diet therapy than other indications. Epilepsy is complicated. There's multiple kinds of epilepsy, multiple reasons why children have seizures. The genetics of epilepsy is exploding year by year. We're finding new genes and new syndromes. And that's sort of the big push of our community, is to find those indications where, it may not even be 15%. So there's a condition called GLUT1 deficiency, about 80% seizure free. I mean, why would you even think of trying anything else? And so we're really trying to establish those indications to get these children on the diet sooner.
Yeah, I'll never forget when that paper was I think that was done, well, maybe it wasn't Hopkins, but where trying to find the mechanism of why there was total remission. And I remember one, it was like overnight, all the seizures on, like, multiple seizures per day. And the GLUT1, so the receptor that allows glucose to go into the brain was deficient, right? So GLUT1 deficiency was an explanation for why some kids would, because you shift them over to ketone fuel for the brain, you can get around this glucose receptor that no longer works or never did work, right? If it was genetic. So of all, let's say 100 people come with epilepsy, how many have GLUT1 deficiency? Do you know?
It's relatively rare. It's something, that is, one of the many indications. There's probably about 15 to 20 that we know about, but GLUT1 is sort of the classic one because it's, the treatment of choice for GLUT1 deficiency. But I'd say maybe, sort of an average year, 2 or 3 of our population that we put on the diet have GLUT1 out of, 50 to 60 children. So, but obviously we're a referral center. So if they're diagnosed with GLUT1, they get them on the diet as soon as possible. But it's relatively rare in the scheme of epilepsy, I think.
How does someone get diagnosed with that? Do they need a brain scan, or is it genetic testing?
Yeah, so that's also changed really just in the last 10 years. There's now a genetic test. It's called the SLC2A1 gene that's in a lot of epilepsy panels. We send these panels off looking at 340 epilepsy genes. It used to be a lumbar puncture, which obviously is more cumbersome. Now with the genetic testing, we find it sometimes even by coincidence. The neurologist is sending the panel looking to see if anything sort of sticks, like throwing the darts at a dartboard. And they get a result back that the child has GLUT1 deficiency, and then they're like, oh my gosh, we need to get them to a keto center immediately. It's wonderful having that genetic test available, because some of these children probably years and years ago, well, for sure, were probably never diagnosed.
And so let's say one of my patients was watching, they have a family member who has a child with this. How likely is the neurologist going to think about it or even send the genetic testing? I mean, what's the penetration of the knowledge of this in this field?
It's starting to get better. It's starting to get better. I think as the genetic test has become more widely available, people are learning about all of the disorders, not just GLUT1 deficiency. And we have more like epilepsy neurogeneticists now in the world that are specialists in this. And the GLUT1 Foundation, which is a wonderful foundation, really has been trying to get the word out through advocacy, through newsletters, websites to families, not only who are diagnosed, but also who maybe aren't diagnosed, to at least think about getting it checked. There's other constellations of physical features that these children have: movement disorders, sometimes early onset absence seizures, cognitive difficulties, and sometimes the clues add up to think about GLUT1 deficiency.
So it sounds like you may have to, or your relative may have to push a little for a neurologist to do this kind of testing, right?
Yeah, sometimes. Yeah. No, sorry, I didn't mean to interrupt you. Yeah, no, it's becoming more standard of care. It's amazing how these panels are done. It's a cheek swab. It's, not even a blood test nowadays. So, there are a lot of neurologists who are just doing it themselves in the office, and they send it off, to the companies to have the panel run. It's getting better. Yeah.
I know you've always been very careful not to talk down other doctors or other practices. I've become a little, been 25 years for us. I've been a little more open of saying, well, that doctor just doesn't know. You might have to push toward asking about a keto diet. There's so many similarities here to the treatment of diabetes, for example, in our population, that doctors will be lobbied or told that drugs are the way to go. Diet doesn't do anything for diabetes, even though it's a condition of elevated blood glucose, blood sugar. You might put two and two together. But so when someone's on one or two medicines, or they're on insulin and nothing works, suddenly they wake up to the idea that diet might help. And in our field, the Verta study has the best data so far out 5 years, and 1 year, 70% of people on insulin came off with type 2 diabetes, which is pretty much an issue of helping someone to stay on now that I see it. So if you, back to your world, if you put people on the diet, they're following it, you must get better results than sending someone home and life happens. But assuming someone is following the diet, you have 100 children with epilepsy. What's the percentage today? I remember the old Dr. Freeman data. What percentage get better, can get off meds, all that? How do you explain the prognosis?
Yeah, no, it's a great question. And again, the families, that's certainly one of the things they want to know. And again, every child is different and every situation can be different. And again, knowing what the cause of the epilepsy certainly impacts the likelihood of benefit. But the data is pretty clear that it's about 50% that will respond. So about 50% of children, I tell families, we do our admissions in groups, usually 3 or 4 in a group. And I tell the family sitting around the table, if you play the odds, 2 of you will respond, 2 of your children probably won't respond. One nice thing about the diet, besides how well it works, is that usually you know pretty quickly. So if you're having seizures frequently enough, within about 4 to 8 weeks, you have a sense of if the diet's going to be beneficial. And obviously, if it doesn't look like it is, we're not going to keep children on it longer term. But it's one of the quicker responding epilepsy treatments. So again, about 50% respond, and probably about 30% of children will have a greater than 90% response. So instead of 100 a day, maybe like 1 or 2 a week, not seizure free, but dramatically better. And then, as I mentioned, about 15% seizure free. And again, many of them, we can reduce their medication. About 20%, we can get them off all medications. One nice thing about pediatric epilepsy is even in some of the toughest cases, there can be some resolution. And we think the diet may accelerate that resolution. But medications can do that too. Sometimes, children will outgrow their seizures, as we like to call it. We think that the diet may help us accelerate that so that they're getting better quicker. Still remains to be proven scientifically, but we've all sort of seen it. So,
one example of that was Charlie Abrams, right?
Mm-hmm.
So the Charlie Foundation, which an example of philanthropy. Your family member is affected by it, and you happen to be the son of a Hollywood producer. You have access to things. So if someone hasn't heard of the Charlie Foundation yet, I guess they've been under a rock. But explain the Charlie Foundation, please.
Oh my gosh, yeah. So the Charlie Foundation is, absolutely responsible for the renaissance in our field. The ketogenic diet for epilepsy has been around since 1921. We actually just had our 100-year anniversary. But it was sort of relegated. Yeah, thanks. Yeah, no, it was exciting for all of us in the field. Lots of memorabilia, lots of history lectures. It's really neat. But for I'd say 70 years, it was sort of relegated to a treatment of last resort, children only. Sort of labeling it being really difficult to adhere to, and a difficult diet and an unpalatable diet. You'd see that sort of written in the literature. And what changed was really the Charlie Foundation. So in 1994, Charlie was, I think, about 18, 19 months old, came from California with his dad and mom to Johns Hopkins, saw my predecessor, Dr. John Freeman, put him on the ketogenic diet with his dietitian, Millie Kelly, and very quickly his seizures improved. And I think by about 2 to 3 weeks, they stopped. He was able to come off his medications and is now, I guess he's in his mid-20s. He's a teacher, doing great. Great example of what the diet can do. And Jim,
no longer following a keto diet. I learned about how some of eating, grew it.
Yeah, and that's part of getting into the science of it. Part of what's so interesting about it is there may be some children and maybe even some adults who you don't need to be on the diet long term. There may be something about this acute metabolic change that happens that maybe even only a month or two can sort of reset your brain in order to stop the seizures, and then you can come off the diet. And there's some research looking into that. But generally, we keep children on for about 2 to 3 years. And then we gradually will see what happens as the diet is weaned, and many of them remain seizure-free, like Charlie. And he's off the diet now. It's just a great example of what a parent organization can do. They not only got the word out, they made movies, the movie with Meryl Streep that was well known, but they also funded research. They did training programs for teaching children's hospitals how to do the diet. They're still incredibly active today, and their website is wonderful. It's charliefoundation.org. And, just has lots of good information, recipes, links to other ketogenic diet centers. But it's absolutely responsible for the renaissance of our neurologic ketogenic diet world.
Well, and it's happening again today, I hope, where, unfortunately, a child who had bipolar, which is a brain disorder. Wait, what you eat affects the brain. Fixing epilepsy. This is irony or sarcasm. That never works well in the doctor's office, but the internet loves it. And so if you had any worry or you didn't think what you eat can affect your brain, it fixes epilepsy in some kids. So anyway, so there's Nat Bazuki, happened to be a child of a wealthy family, and now the Bazuki Foundation and family is putting an effort into studying a different brain disorder, the psychiatric problems, major psychiatric problems. And hopefully that's going to bear similar, not just advocacy, but the science that needs to be done still on, what you just said. How many people get better? Is it worth doing? How fast does it happen? That kind of surprised me when you said that the improvement happens so fast. So you kind of know who to keep it with, because we don't see some keto adaptation changes until 6 months, full muscle fat adaptation. in the movie Serial Killers, Cereal, Serial Killers 2, they keto adapt a couple, and it took them 6 months to fully fat adapt. But this is the muscle, not the brain. And then they went into a rowboat and rowed from San Francisco to Hawaii and broke the world record by 15 days. So it's kind of heroic effort, but that's we're learning different. Every organ, of course, is under a different silo in our medical world. That the brain is an organ, but I'm an internal medicine doctor who has very little training in the brain. But I know more about muscles in the heart, that's very interesting about how often or how fast it would work. I wonder, how have you evolved the thinking in the implementation of the program? And I will never forget, again, the paper you wrote that talked about a modified Atkins approach that kind of took away you have to feed butter through, to try to get to if it's ketosis that is having the benefit, maybe you could be a little more relaxed on the treatment.
Excellent. No, it's, one of the things, I often tell, my trainees and medical students, the only thing that doesn't change is change. And, what I learned, what Dr. Freeman was doing even before me, was really questioning a lot of traditions and anecdotes, again, going back to the 1920s about how to do the diet that, had some scientific basis, but really, when you really push hard, didn't clearly show evidence for why that was necessary to help a child's seizures. It's amazing. You look back in the 1920s, they would fluid restrict children, they would calorie restrict children, probably sort of artificially raise their ketones or what it looked like in their urine, but maybe, really didn't make a difference for their epilepsy. And so we started to see in the 1990s some articles, a lot of them by dietitians, looking at aspects of how we started the diet. Do we need to admit them? Do we need to do a fast? Do we need to be so strict with our ketogenic ratio? Maybe we can be a little bit less restrictive. And it's absolutely wonderful for the field, not only to help maybe reduce the side effects by being on such a super high fat diet. Again, our children are typically like 92% calories made up of fat with the classic ketogenic diet. But also, can you maybe do it in different ways for different cultures, different religions, to make it more accessible? That's, one of the things that was a problem in our field was people would say, well, you can't do it if you're vegetarian. You can't do it if you're vegan. You can't do it if you, can't be in the hospital. You have to be in the hospital. And say, well, wait a second. Maybe there are sort of alternative ways, or as we call them now, alternative diets that can be sort of adapted to each individual child and get them on the diet where they would have been discouraged before. And it's definitely expanded our population and helping children that we couldn't have helped before. The modified Atkins diet was sort of created by us at Hopkins as sort of a change versus the classic Atkins diet, but sort of keeping the carbohydrates at 20 sort of indefinitely, not going up sort of periodically, and really sort of encouraging the fat. That was sort of a big aspect of our counseling to the families. It's not that fat is okay, protein is okay. It's really more fat is critical, and protein you have to keep an eye on because that's anti-ketogenic. And it's done by, families not coming into the hospital. It's done a lot, again, for teenagers and adults nowadays. And we teach them how to read the food labels, not how to weigh and measure on a gram scale. So it's a different way of kind of getting to the same goal. There's a low glycemic index treatment out of Boston. There's a diet called the MCT diet, which actually goes back to the 1970s, looking at using more MCT oil versus long-chain triglycerides that maybe allows more carbohydrates and seems to work equally well. People are really creative out there, and coming up with various ways to kind of question, again, what we've been doing for years. And it's just wonderful for our families.
So a modified Atkins is beneficial? It works as well or almost as well?
Well, yeah. I mean, if you look at studies, there have been some comparing the modified Atkins diet to the classic ketogenic diet. There have been some studies out of India looking at classic ketogenic to modified Atkins to low glycemic. They're all generally similar, it seems like, with maybe a little less side effects with modified Atkins, which makes a bit more sense. But, for every child, it can be different. We've had children And we tell families you can switch from one to the other if it's clinically deemed necessary. So we've had children start with a modified Atkins diet. They're 95% better. We'll see them and say, maybe let's switch you to a classic ketogenic diet and see what happens. And there are some of those children who became seizure-free when we did that. Most commonly, it's the other way around, Eric, where they're on a strict classic ketogenic diet. They're having compliance issues. Some of them are reaching puberty. Like, all right, maybe let's back off a little bit just to keep you on a dietary therapy, and we'll go to like a modified Atkins diet and try to see if that works. And usually it does.
Yeah, that's just so interesting. How has your field addressed the new technology of ketone measurement? Now, I get people coming to me with reams of ketone data now, glucose and ketone, the blood, the breath, the urine, and it doesn't always correlate with the disease modification that we're trying to modify. But have you incorporated the ketone measurements, and does that matter?
Yeah, your clinic sounds like my clinic, Eric. Yeah, I have families come with like 3-ring binders of ketone measurements, and it's amazing what we can do now. And the meters are getting smaller and easier. There's breath meters now that are, really accurate. It depends on the situation. Obviously for really young children, we, kind of will lean more towards urine ketones. It's a little less invasive. You can check blood ketones in the clinic, but there are some families who really find that for their child, ketones really matter. And we keep track on a calendar, and we try to correlate that with seizure control. And in those children, I may recommend getting a blood meter so we can be really more precise. The GLUT1 families, which we were talking about earlier, it's in fact recommended that they do blood ketones because it seems to be more correlated with their outcomes. But there's a large, I'd say, majority of these families that we treat with epilepsy that, it's sort of a marker that they've made the metabolic change. Most of our children, they're in large ketosis. So large in the urine, maybe 3 to 4 millimoles in their blood. And it may, vary day by day, but usually not a lot. Not a lot where I would say you need to be checking your blood ketones on an everyday basis. It's not really going to change what we're doing. But, periodically, sure, it's definitely more accurate. Absolutely. But some of our families will, in fact, do it more regularly. But most of our families are still checking urine ketones, at least at Hopkins.
But do you require that people do it? Or is it optional?
Yeah, we tell families the first couple months, we really do want to get some data. So, on their calendars, check it, write down what their ketones are. Keep track of their weight, keep track of their seizures. And as time goes on, we can loosen up on that as well and tell them, okay, maybe once a week or a few times a month, check your urine ketones. If there's a problem, seizures, increase for some reason, we don't know why, check your child's ketones. Make sure they didn't get a hold of something that knocked them out of ketosis. But for most children, we can start backing off over time. Again, whatever we can do to keep them on the diet longer, make it less onerous for the family, easier, less labs, is sort of where our field is starting to head.
Well, there's always that balance of what you ask people to do, whether it, rock tips over the boat. So it's
right.
So I wonder, has there been a formal investigation of the ketone level and extent of seizure reduction? Does the level of ketones matter?
You would be amazed. After over 100 years, there's been very little studies that have looked at that, and part of it is how hard it can be. Yeah, I know it would be a very difficult study to do because seizures fluctuate, ketones fluctuate throughout the day, and then you can get into what are the families witnessing versus what actually could be happening in the brain, and should we be monitoring EEGs to do a study like that, electroencephalograms, and see if those change? Yeah. So it would certainly be a complicated study. It's been done. There have been a few studies that have shown a slight correlation, some that have shown that if the ketones are stable, that's better than if they fluctuate. Hard to replicate that in other studies. It seems to be that if you are at a ketogenic level, so again, 3 to 4 millimoles, on a blood ketones or large ketones, you're kind of more likely to at least show compliance, and then that could be a surrogate for you're doing better on the diet. But it's really hard to say what number is correlated with control. It's in many ways, we tell families it's like drug levels, right? For, if you're on Dilantin or you're on Keppra, for some patients, they don't need to have a high level. For some parents and for some children, they do. And it's the same thing, I think, with ketones.
it sounds like as long as you're in ketosis, that's the main thing.
I think so. I think so. Although, if you look at the low glycemic index treatment out of Boston there, if you try to check urine, they don't seem to be in ketosis. It's very scant in blood, which suggests maybe there's another mechanism at work beyond ketones, which is super exciting too.
The big confounder is maybe it's just the absence of the carbs.
Could be. Could be. I mean, that is actually their theory that, it's maybe keeping your blood glucose stable for some epilepsies may be more important than being in ketosis. Fascinating work. Yeah.
Yeah. Wow. So now there's an old brainstorming technique where you just flip everything upside down, as ridiculous as it seems. It's just for brainstorming, you flip it upside down. So what if? And so I have I've been around the country talking to people at meetings. You have too, and people come in and tell you things. And I've had a few people, mothers, change their diets, and they send their breast milk off to labs. There's I think one in UCLA that'll do the breast milk, and they come in and they tell me that the breast milk changes if they're keto. And then I traveled to Jakarta, Indonesia, and the pediatrician next to me says the children develop even better if they're in ketosis. I'm like, what? Yeah, and so now, what if? So and actually, I know I'm leading up to this. Mary Newport, who's a neonatologist, retired now, makes the claim that children are born in ketosis, that babies are born in ketosis, and that we basically turn off ketosis by giving carbs, and yet the lactose in the milk would seem no. So this mother who checked the ketones in the child was in ketosis when she was breastfeeding on a keto diet, and the gentleman at the meeting who was a speaker walked by at the same time and said, "Oh, that makes sense to me. There are cultures around the world that ferment lactose that doesn't get absorbed as a sugar." So what if we have it all wrong and we should always be in ketosis, and the babies should be in ketosis, and we give them the seizure disorder by feeding them carbohydrates? I mean, I know this seems ridiculous, turning it.
Yeah.
Has that ever occurred to you that maybe?
Yeah. So it's an interesting question, sort of in two parts. I mean, and you're right. I think there was a recent case report of a mother who was on a ketogenic diet, and they sort of analyzed her milk. The child had epilepsy, and she was able to keep the child in ketosis by breastfeeding. That was the first time I'd ever heard of that. I think pretty recently.
I didn't know about this.
Yeah. I'll send you the reference. I think it just came out pretty recently. Because in general, like, even though it's, you can do it, there's most of the times that we've heard about this from pregnant women or women who are breastfeeding and they're in ketosis, is not enough of the ketones that cross over, and that the breast milk itself still is high in carbohydrates. It may have more fat, but it's not like the 90% fat ketogenic formulas that exist. Right. So I think it would be they'd have to be on a very strict, I'll have to read that case report again. They'd have to be on such a strict diet.
But the thing that never occurred to me, and it was just because this evolutionary biologist he actually was the keynote speaker at the meeting, and he gets up with a rock and goes, "This is what changed human history." Great talk, by the way, because it allowed us to cut, our ancestors. That's how the theory goes. But he's walking by and he says, "No, the lactose in the milk's not an issue because it will be fermented, and the baby will be in ketosis." And the mother was kind of shocked because the only couple times she checked, he was in ketosis. So, and then of course, how long was the mother keto adapted into the breast milk? So I learned a while back that the normal range and what normal breast milk normal is entirely dependent on the environmental situation of normality, which for most papers and textbooks will be people eating carbohydrates, right? So the normal range for breast milk, that's based on women who eat carbs. Anyway, so that's fascinating. I didn't know, and yet this had an effect on the child. Was the child in ketosis then?
I don't think so. I think, but the ketone, there was at least some trace levels, maybe. It wasn't like nutritional ketosis, but I guess enough ketones had crossed over into the breast milk that the child, without any other obvious reason, had some seizure benefit. So it's very, very interesting. But yeah, no, I think it's an interesting question. People are certainly looking at using the diet for babies. People are looking at using the diet as a sort of preventative sort of therapy, right? We do it more reactionary, right? The child has epilepsy from various reasons, and then we'll put them on the diet and sort of alter the course of their epilepsy. But what if we knew, which isn't always possible, but can sometimes be, that somebody, doesn't even have to be a child, is likely to develop epilepsy? Could you put them on a ketogenic diet in advance of whatever insult or genetic change is likely to happen, and then prevent them from maybe having epilepsy in the first place? Or if they do, it'll be a milder course of their epilepsy. And so people are looking at like traumatic brain injury in that way. I think the military is interested in it for preventing, some of the brain injury and preventing epilepsy from traumatic injury. There was a very sort of famous case of a child with GLUT1 deficiency, was born to a mother with GLUT1 deficiency. And so the mother was on a ketogenic diet. They're like a celebrity in the GLUT1 community. And she became pregnant. She stayed on the diet. And as soon as the baby was born, it's autosomal dominant, they suspected the baby was going to have GLUT1 deficiency, put her immediately on a ketogenic diet, checked her genetically, and she in fact did have GLUT1 deficiency. And I think she's now like 8 or 9 years old, completely normal, 100% normal, never has had a seizure, no cognitive decline, sort of a proof in principle with one patient of what if you knew, and she has GLUT1 deficiency. It's not like it went away or,
Well, but you're assuming everyone with GLUT1 deficiency gets seizures. Do we know that for sure?
That's not true. Yeah, some of them don't. Yeah, that's true.
All right.
But they can have, no, you're absolutely right. But, I think some of them, the majority will have cognitive decline by a certain age. A lot of them will have movement disorder abnormalities. To be completely normal at 8 or 9 is pretty unheard of in the GLUT1 community, even those who don't have seizures. Yeah.
In some area, so you might screen a newborn, for different hereditary things, including a seizure disorder.
Right. Well, potentially for some that have genetic causes. So yeah, in fact, getting back to GLUT1, they're actively working to have it on some of the newborn screening panels, because we know there is a treatment that is sort of remarkable for changing the course of their disease, and early identification seems to be really important, at least what we've seen so far. And this is, again, a case of one, but quite dramatic.
I wonder, does the history of epilepsy give any insight into this? Like, did the prevalence go up as the carbs went up, or that, as the or even protein? You used a term that I hadn't heard in a long time, the anti-keto effect of protein. I have to keep that in mind, that as you increase the protein, you can elicit an insulin response, and that turns off ketosis. I think that's the mechanism still.
I think that's probably right. But it's again, we try to get them into this high ratio of fat to carbs and protein combined. And so people think of carbs, of course, but protein also can be sort of anti-ketogenic. So for some patients, they do fine, but for some, we do have to kind of cut back a bit on their protein if they're losing their ketones. And it seems to be relevant for their seizures. But yeah, it's a common question that's asked, at least from what we've seen epidemiologically. It doesn't appear that there's been an increase in epilepsy, which again, you'd expect with the increase in carbohydrate consumption over the last 100 years. It doesn't seem like that. And in regions, parts of the world where they maybe have a higher fat intake, it doesn't seem like there's less epilepsy. Again, epilepsy is again, mostly genetic, sometimes structural abnormalities that are rarely metabolic. I think there are some metabolic conditions that can cause epilepsy, and perhaps a ketogenic diet, if used in many children, could reduce that risk, but it's a small proportion of the epilepsy group. Many of them, again, are genetic causes that are not due to metabolism changes.
Well, even I wonder, could you describe what is epilepsy? Is it to an internist? I'm not a neurologist, or to the general public. Of course, has a lot of different, could be grand mal or generalized seizure, the classic, someone has tonic-clonic motions and loses consciousness, but they're also the less severe. Do we know what's going on, or is it a lot of different things could be creating a seizure?
Yeah, no, it's very complicated, and for sure, there's a lot we still need to learn. I mean, we know again that many genetic causes are usually like a channel disorder, sodium channel or GABA. Some of the neurotransmitters are off. A lot of times, as I mentioned, it could be structural. Their children are born with brain malformations, gray matter, white matter, not in the right places, and that can, of course, set them up for seizures. Sadly, trauma to children can predispose them, just like adults, to having seizures and epilepsy. So there's many different potential causes, and there are some where we just don't know. They have seizures, and all the tests have come back normal, and those are cases that often do, in children, they can grow out of those, but it's still a mystery in many cases. But even knowing those causes, Eric, like we don't know why seizures start at one age, go away at other ages. We don't know, like on any given day, at any given minute, like why a seizure happens. And then we also don't know, why does it stop? Most seizures are 30 seconds. Why doesn't it just go on indefinitely? But seizures stop after 30 to 60 seconds in most patients. There's a lot we're still trying to learn, as an epilepsy community. Just, of course, like why we're trying to learn, like why the diet works. We also don't know a lot of why some of the drugs work. We know what they affect, certain channels, certain neurotransmitters, many of our drugs, but why do they work specifically for one epilepsy but not another? And how do they prevent those channels from causing a problem, again, on any given day? There's still a lot of work we have to do. But epilepsy is common. It's 1 out of 26 people. It's incredibly common. And it's one of those disorders that, if you look at someone, you wouldn't know that they have epilepsy. And that's a good thing, but it also, becomes one of those things where it's a disorder in the shadows a lot, because it's not so obvious to people that somebody may have epilepsy or that it's as common as it is. So, we're trying to get the word out as an epilepsy community, not only about the diet, but about epilepsy and, getting aggressive treatment and getting to an epilepsy center as quick as you can.
That's great. So the Metabolic Health Summit meeting is a way for epilepsy, ketogenic diet for epilepsy, ketogenic diet for diabetes, and of course it was called Atkins protein power, although it's a banned thing back there. And the newer scientists of keto all get together once a year, and Metabolic Health Summit is a great place. I've learned so much. And I remember asking if someone with epilepsy as a child and they're on the keto diet and sensitive to carbs, if they had just a bite of a candy bar, they might have a seizure. I was blown away. In my world, you have a bite, your blood sugar goes up a little, you don't lose weight for a day, but the consequence of having, in our world, it's called cheating, right? Right. The consequence of having that might create a seizure. Is that right?
Yeah, it's thankfully not universal, so because children are children, right? And even adults who are on the ketogenic diet for epilepsy, it's hard. It's hard to kind of stick to it 24/7. I'm sure you know that, especially in the adult clinic, compliance is probably the biggest issue that they're working with. Whereas in the pediatric world, it's more side effects and sort of, trying to sort of improve seizure control. And not that they're not doing that on the adult side, but it's less the compliance issue for the young children. The parents can, for the most part, make them do it. But, that was something I was certainly taught. We were taught even that the carbohydrates in liquid medicines can sometimes throw children out of ketosis. I was taught as a fellow that some of the sunscreens you can absorb carbohydrates from the carbohydrates in sunscreen. And there have been, anecdotes of those children being knocked out of ketosis. There's always a case like that. We, of course, at least to start, try to be very strict and discourage that. So when families ask, well, can they cheat once in a while? I usually say no, try to be strict. If they get a hold of brownies, it could certainly knock them out of ketosis. But as time goes on, we learn about each individual child, and some have done that and had no consequences, and some obviously a little bit of carbs and they've had a seizure. It's incredibly, humbling to know that for each child, it can be so different, and, one rule doesn't fit all. So we usually start pretty strict, and then we maybe loosen up a bit after a few months in these children if we notice that maybe some of those things aren't causing a problem.
Yeah, well, the consequence of that, I've seen some dietitians who have been trained only in the ketogenic diet for epilepsy will think that adults have to be that strict, right? And so what we're talking about with adults and even the modified Atkins is not as strict as what you've been taught about the children with needing a very strict version of was it really 95% fat? Is it?
Yeah, 4-to-1. You're getting pretty close to that. Yeah, and some centers will even go higher than that. Yeah.
So I'll never forget. It's one of these articles. You just don't forget that they looked at the lipid values of children on the ketogenic diet, and then they and the media kind of generalized. Well, therefore, adults on a Atkins or a keto diet are going to have this terrible lipid phenomenon, and it was entirely in the old cholesterol is bad paradigm. What have you learned since that time? I mean, now I'm much more comfortable talking about triglyceride and HDL as the main markers. Do children on a ketogenic diets get higher risk of other diseases because of the diet they follow?
Yeah. So, great questions. I think as time has gone on, we've at least seen, as we follow these children, done some long-term studies that we don't seem to see cardiovascular risk years down the road, which is obviously reassuring. We've also seen that in many of these children, they do have an increase in their cholesterol. They have an increase in their LDLs, but it kind of levels out at around 6 months, 9 months, and then it kind of comes back down, sometimes below normal, which is pretty impressive. And most of the time, my intervention when we check the labs and if we see there's a problem is usually to wait. Usually I'm like, let's just check again in 3 months, and it usually will come back down. And if not, my dietitian may make some changes to the kind of fats they're on, or maybe even lower their ratio. Sometimes if we do see that there's a surprising change, we may actually suggest the families get checked, the parents, and see if there is some familial hypercholesterolemia that runs in the family. We've identified a few parents where that's been the case, and, good for the families too, not just the child. But, we don't know a lot about the impact of this on a child. Our adult center, as you'd imagine, is very interested in this and the ramifications for adults. And so they're looking at apolipoproteins, they're looking at the subparticles, because again, obviously it's much more complicated than just total cholesterol, LDL, HDL, and to really see what impact that has. There have been some studies in children looking at other outcomes like carotid distensibility, looking at sort of heart function, and for the most part, they seem to be fine. But, something we definitely need more information on. And again, the other part of it too, as I mentioned, at least on the pediatric side, is it's usually a couple years, right? So I've had some children where their lipid values were definitely abnormal, and I'm like, well, let's see. If we do need to go beyond 2 or 3 years, okay, we can make some more aggressive interventions, so to speak. But in most of them, I'm like, 2 years, we're not sure, or we don't think it's going to have any impact on the child. It doesn't seem to so far.
That's reassuring. And there's an ongoing study right now in the adult world we're following very carefully. The Citizen Science Foundation funded a study looking at people who have high LDLs, self-describing a low-carb keto diet on average for 4.5 years. And they are all sent to a lab or a testing center in LA to get a CT angiogram, not just a coronary calcium score, but half of these people had no coronary calcium or no blockages on CT angiogram, despite a 4.5-year duration of even up to 580 was one of the LDLs. They did a comparative. It's at least double the LDL you see in Miami in a similar matched population. And the baseline data were presented. We're now anxiously awaiting the 1-year data where they kind of know they're doing keto. Before, one of the limitations is it was self-described, right? But at a year, we'll see, and I'm told the data are imminent, coming out any day now. Heard that for a while. But again, it kind of says relax about this LDL thing. The average HDL was 90 in this group. So we really high. So is it possible the good and the cancels out the bad if we use the old paradigm, or maybe it is just triglyceride and HDL, and maybe LDL wasn't a big deal ever, but that puts you into this quackery, and especially at a place like Duke, cardiology belief system has that in their mainstream treatments. So, and there is some value to it. It's just not, the only thing one can do. So I encourage people that actually the diet change is an intervention. So don't forget, if a doctor just says you need a pill, or you're actually doing an intervention, and good. Well, it would conversely, if that LDL elevation always had a problem, you would have seen an epidemic of heart disease and stroke even at 2 years. And so that's reassuring that you haven't seen that.
Yeah. This is great. I mean, this is why I love the Metabolic Health Summit meeting. I learn from you guys. You learn from us. It's a great way to share information. And I tell families, I went to this meeting, and they're not so worried about this number or that, and this is what the data is saying, and this is important, for your child with epilepsy. So it's great information.
Well, again, thank you so much for taking the time to talk. And if anyone ever asks me about, thank you for the email replies you sent back.
Oh, sure.
I've referred a few folks or concerned relatives your direction of how can people find you, and what are you into now that you want people to know about?
Yeah. So, no, for sure. As we mentioned, there's a lot of great information on the internet. Charlie Foundation, is a great website. Matthew's Friends is the similar charity out of England. We have a pretty robust website at Johns Hopkins about the history of the diet and our center. That's a great way to reach out to us. And also the Adult Epilepsy Diet Center has information on all of our websites. We have a ketogenic diet book that we revise every 5 or 6 years, written primarily for parents, but now we have growing chapters on adults. That talks a lot about the history of the diet, talks a lot about non-epilepsy situations and indications too, and that's a great resource. But also, anyone who's listening, speak to your neurologist. We're changing. Again, it's been over 100 years. There are neurologists out there that don't believe in it, as we sort of said, but it's pretty few. Most of them are maybe not doing the diet at their center, but they're willing to refer out and say, oh, that's a great idea. Go to Hopkins, go to Duke, and they can help you. It's a changing world for us in the neurology field. I think there's a wider recognition of the diet as being valuable. It's, as I often say, it's kind of mainstream, in our world. Not everyone's doing it, but they know that it does work, which is obviously great. So yeah, anyone who's, interested, those are some great resources, and, feel free to reach out.
Well, thank you for your tireless effort. You and your group are really, while Charlie Foundation might have made a presence here, your academic hold, and then looking at the science, see, maybe we can have this evolve over time. I'm reminded of why do we cut the roast on both ends? And you finally learn back that grandma didn't have a pan that was big enough for the roast. So,
right.
But we have to keep questioning and hopefully improving what we do. Thank you for putting your mind to that.
Oh, yeah, absolutely. No, it's been my pleasure over the last 20 years, and the next 100 years, I think, are going to be really exciting for all of us.
Well, I hope there are more than just the two of us who care about our patients. I know there are more, but
there are.
Take care, Eric.
Okay.
Thank you so much.
Thanks, Eric. Yeah.
Bye-bye.
Bye.
If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.